Good afternoon, everyone. I would like to thank you for joining, and I'd like to thank SMFM for hosting this webinar today. My name is Elizabeth Stringer, and I am honored to be the moderator for today's webinar. I work at the University of North Carolina. I am a maternal-fetal medicine specialist there, and I am the current head of the Society I'm the Society for Maternal-Fetal Medicine Global Health Committee. I lived in Zambia for 10 years before moving to North Carolina about 8 years ago. I would like to welcome you to the practical guidance during the era of COVID for obstetricians in low and middle income countries, presented by Drs. Adesina, Dr. Wright, Dr. Wolfe, and Dr. Zash. Before we begin, I'd like to take a moment to share a few housekeeping notes about today's webinar. This webinar is being recorded and will be available to view on demand from the SMFM website. Following the lectures, there will be a 20 to 25-minute Q&A segment. You may enter your questions using the Q&A box at the bottom of your screen at any point during the broadcast. If you would also enter which country you're asking from, that would be helpful. Please refrain from using the chat feature to ask the panelists questions. We promise to get as many questions as possible answered during the time allotted. And after the webinar is finished, we will be writing up all the Q&As and distributing that. So without further ado, I'd like to introduce Dr. Adesina, who is an associate professor of Obs and Gyn at the University of Ibadan in Ibadan, Nigeria. Thank you so much. Dr. Adesina, you're on mute.
Thank you very much for having me, and I want to thank the committee. I want to thank the society for having me. I do believe you can see my screen. Oh goodness, okay, let me put this on.
We can see it, yes.
Okay. So I'm taking the Nigerian response to COVID-19 from a public health standpoint, strategy for testing, and is it different from pregnant women? Of course, by now we are all familiar with the identification of the virus in China. When it was identified, it was named, and then it landed in Nigeria 27th of February. That was when we had our first case. It was an Italian who flew into the country in Lagos. And since then, of course, the figures have increased. And you can see there are 36 states in Nigeria. And presently, practically all states except two have recorded cases. Many factors have contributed to this. Of course, there was the continued importation of the virus before closure of the airspace. Attendance at social events continued, and of course, this resulted in amplification of the host locations and multi-state spread. There was also introduction of the virus into settings prone to amplification, such as high-density urban areas. Of course, limited testing, as a lot of places all over the world, and transmission among asymptomatic persons also continue. And the result now is that we have over 7,000 people who have been confirmed positive. I think we come after South Africa with about 17,000 and Algeria with, I think they are just above us as well. If you look at the demographics, a lot of that is actually, there's no epidemiologic link. The travel history, just about 3%, contact about 22%, about 56%. We have no epidemiological, so there's a lot of community transmission going on. Now, the result of this first case is that there was activation of the country's National Coronavirus Emergency Operation Center. With the Ebola epidemic virus disease that happened in 2014, we were able to quell that, and it received praise from the international community. That was the foundation on which the subsequent Emergency Operations Center and the Nigerian Center for Disease was built. So we had time to at least provide information to Nigerians, provide capacity building for healthcare providers, and also to strengthen the laboratory system. And I think that gave us a little time so that by the time the epidemic came, the virus came into the country, we were a bit prepared. Other public health steps that were taken to mitigate the spread included travel restrictions from countries with widespread sustained transmission, screening and self-isolation measures for international travelers, and recommendations to limit mass gatherings. Those recommendations are still ongoing at the moment. And then we also have stay-home orders, closure of schools and non-essential workplaces, and more recently, the use of cloth face coverings in public areas. Now, the Ministry of Health has also prioritized testing as a key strategy. They've identified that is one important thing that we also need to do. And there are plans to rapidly scale up diagnostic testing to all 36 states. The Nigerian CDC intends to work with donors, partners, and the private sectors. As at April 14, 2020, there are 12 functioning testing facilities able to do a minimum of 2,500 tests. And it is hoped that over the next few weeks, that will be increased. To do that, a multi-pronged approach has been adopted by the Nigerian CDC. The first one is that they intend to expand on the existing laboratory network. That network is used to monitor viral hemorrhagic disease in the country. If that can be done, it will increase the testing output from 2,500 tests to at least 3,500 tests daily. We also want to leverage on the capacity through the high throughput HIV molecular testing laboratories. A lot of this has been set up through the PEPFAR funded programs. Again, if we're able to do that, we'll be able to add another 3,500 tests. Prong 3 aims to repurpose point-of-care tuberculosis testing gene expert machines for COVID-19 testing. That can add additional 1,300 tests per day. So, of course, testing is so important to know what is going on in the country. These, of course, are not without risk, challenges, and mitigating actions. Where pregnant women are concerned, we all know that recommendations are dynamic and evolving. But as long as this epidemic continues to spread, there'll be infections that will be encountered in different countries, regions. So it is important that pregnant women, their families, and healthcare providers receive accurate information as possible. When these women are positive, we all know that resources need to be mobilized. For example, ideally, they should be admitted into negative pressure isolation ward, which have multidisciplinary expertise. Resources for personal protective equipment also need to be made available. Many guidelines have advised prioritizing the testing of pregnant women with suspected COVID-19 at admission. But for low resource setting, this is a challenge, especially if it's reverse transcriptase polymerase chain reaction, and even for proxies such as chest x-ray, CT, pulmonary ultrasound. Those things are not so readily available in a lot of places in low resource settings. So for now, what a lot of centers are doing, a lot of maternities are doing, they're offering screening, symptomatic screening, signs and symptoms, history. Have they had any close contact with a confirmed case? Are they traveling from areas with ongoing transmission? But despite this, sometimes you have asymptomatic patients or pre-symptomatic patients who will present to you in the labor and delivery unit. And this has implications, of course, for the healthcare staff and the management of the labor, and even other patients who are also in the labor ward at that point in time. So many are advocating that testing for all patients upon presentation may be appropriate. Of course, we all know that there are instances and there are activities that go on during labor that increase the possibility of transmission, such as when the patient is forcibly exhaling in labor, or if general anesthesia, which you all know are aerosolizing procedures. And then, of course, there can also be loss of feces, which can contain the virus and spread the infection during labor. So those are all potential risk of infection to the healthcare provider and other women who may be in labor. So as I conclude, I know that as the epidemic continues, we all need to plan, we all need to be proactive. And as we try to provide appropriate clinical management for our patients, we must also ensure that we protect the healthcare professionals. There are, of course, challenges. Global shortage of personal protective equipment, infected pregnant women showing up directly to delivery rooms in advanced labor, And of course, there are reports of transmission in hospitals and deaths among healthcare professionals, which of course are serious concerns for everybody. But if we improve on our governance and we continue to support, educate, and train healthcare personnel, hope that we'll be able to mitigate some of these challenges. Once more, thank you very much for this opportunity.
Thank you so much, Dr. Adesina. I think it's really important, or this epidemic has shown us the importance of knowing what's on the ground, talking to our colleagues, and sharing information. I'm going to save questions until the end. And I'm now going to introduce Dr. Rodney Wright, who is a professor in the Division of Maternal-Fetal Medicine at Albert Einstein College of Medicine in New York. Thank you, Dr. Wright.
Great. You're seeing my email there. Sorry about that. So good afternoon, good morning, good day to everyone. Just in the way of background, I am a maternal-fetal medicine specialist, as Dr. Stringer just mentioned. I've done a good amount of work in research-limited settings. In particular, I was a part of the Human Resources for Health program in Rwanda. And I've been on the board of directors for the AIDS Healthcare Foundation for the past 15 years. And we currently have over 1 million patients, 1 million HIV patients now in 43 different countries. So I have a bit of experience when it comes to global health. And with COVID-19, unfortunately, I have a lot of experience. We are located in the Bronx, which is one of the boroughs of New York City. In the Bronx alone, there have been over 40,000 cases, confirmed cases of COVID-19, and over 3,000 deaths. We are participating in a cohort of patients, institutions across New York City, looking specifically at our prenatal patients. And amongst our cohort, we've had over 241 deliveries. At Montefiore alone, we have almost 200 pregnant COVID patients. Some of those are still pregnant, but in various stages of their pregnancy or postpartum. So I want to share with you some of our experiences and some of our clinical pearls, both administratively and clinically, that we've gained over the past 3 months. And then following me, Dr. Dana Wolfe will share with you some of our more practical experiences and protocols that we've been using. So first and foremost, I want to make sure everyone understands that asymptomatic spread is truly a problem. One of the things we've seen with our New York consortium is that 61% of pregnant patients with confirmed SARS-CoV-2 infection were asymptomatic at the time of presentation to the labor floor. Some of those patients went on to show symptoms later, but these are patients who all presented to the labor floor at some point during their pregnancies and were confirmed to be SARS-CoV-2 positive. Other thing we've known, our basic scientists here at Einstein have been doing lots of research looking on the molecular biology and virology of the virus. And they've seen that even amongst persons who are asymptomatic, there can be extremely high levels of viremia, which leads to what we have called the super spreaders, some folks who are able to infect large numbers of folks with R values greater than, very high R values greater than 3. So that being said, in areas of widespread transmission, we really must assume that everyone is infectious, including fellow staff members. Many of the ill staff members that we've had here at Montefiore became infected at home, but amongst those who became infected in the workplace, many have acquired it from coworkers as opposed to patients. And this makes sense. You know, when you're seeing a patient who's suspected of having COVID, you're wearing a mask, you're wearing face shields, you're washing your hands. But amongst coworkers, if you are in the break room eating or in the cafeteria, you take your mask off, your guard is down, and if there's an asymptomatic person that's amongst your cohort, you're much more likely to acquire the disease. Fortunately, overall, the prevalence rate for antibody positivity so far in our institution is about 17%, which is still significant. But compare that to the estimated positivity in the Bronx, which is about 34% right now for antibody positivity, which is quite astounding, especially considering the Bronx is a borough of 1.3 million people. One of the other things we did was we cohorted our providers, so that would help, once there is a cluster that develops, to help decrease the spread to other areas. So say if we rotate through the outpatient setting and the inpatient setting. So you spend 2 weeks outpatient and then another 2 weeks inpatient, as opposed to going back and forth the same day, being in the clinic in the morning and being in the hospital in the afternoon. So other thing we need to make sure is implementing screening. I know Dr. Adesina was mentioning screening and outside of the health facility. So one of the things we very strongly recommend and suggest is there's screening before entrance into the facility, both for patients, visitors, and staff. Upon entrance to our facility, every person, both patients, visitors, and staff, has their temperature checked and their questions asked regarding their symptomatology. Another very key important point is making sure there's masks for everyone, patients, visitors, and staff as much as possible. Remembering that most transmission is via respiratory droplets. So a standard surgical mask or even the homemade cloth masks that many people are making, and even in resource limited settings, most people are able to make, can significantly reduce the amount of virus that can be disseminated from a person who is actively infected, whether they know it or not. I know I'm sounding paranoid, but in times like these, sometimes you have to be a bit paranoid, but really suspect COVID-19 for any patient with a fever when there's widespread community transmission. One of the unfortunate things we've seen is that SARS-CoV-2 can be a great imitator. The signs and symptoms can vary from very common ones like we talk about all the time, fever, myalgias, and cough, to very atypical ones like diarrhea and nausea and headache. Many sick COVID patients at our institution had some degree of blood pressure elevation, along with abnormal LFT, liver function tests, and thrombocytopenia, making the diagnosis of preeclampsia and HELLP syndrome very difficult. Interestingly, along with that, we've seen an increase in eclampsia, which is something we rarely see here in the Bronx, but we've had a number of eclamptic patients who've presented and are believed to have been or later were confirmed to be SARS-CoV-2 positive. And then one very significant clinical pearl is that the most critical time for most of our patients has been about 5 to 7 days after the onset of symptoms. Patients either are on their well on their way to being recovered, or they decompensate during a time of cytokine storm that happens around that period. And the reason why that happens is because we've learned over time that SARS-CoV-2, COVID-19 is a very multi-organ disease. We all are very familiar with what happens in the lungs with cough, pneumonia, hypoxemia, and ARDS. But one of the things we're seeing is that it infects other parts of the body. In particular, the heart and blood vessels. The virus actually is able to attach to ACE2 receptors that are found in blood vessels, which can lead to myocardial infarctions, DVTs, cerebrovascular events, and myocarditis. It was estimated from one study that about 20% of hospitalized persons with COVID-19 actually have some form of cardiac damage. And it's also this level of attachment to the blood vessels that may contribute to the thrombotic events that are very common. And also there may be endothelial damage associated with this virus attacking the blood vessels, which leads to the preeclampsia-like picture that we see very commonly. Other things to keep in mind, about 50% of hospitalized patients have transaminitis, and these LFTs often peak after the symptoms begin to resolve. Renal failure is another critically issue for many of our patients. We were all worried about ventilators, but actually the ventilators, we were able to get some ventilators from our government and from other sources, but we began to run out of dialysis machines for the very sick patients who needed dialysis. And then lastly, the lower GI tract is rich in ACE2 receptors, so about 20 to 50% of patients present with diarrhea. The last point I want to make is that the sensitivity and specificity of our tests can vary greatly, and there are many factors that are believed to contribute to that. Factors such as method of collection. Did you actually go all the way back to the nasopharynx as opposed to just getting the nares? The transport media used. Is it truly viral transport media that was used that is in good condition to transport the test to the lab? And the amount of time from the specimen collection to processing, all those things can affect the results. Therefore, if a patient has classic symptoms of COVID-19, assume they are infected even if they have a negative PCR test. This has been a hard thing for us to kind of deal with and grapple with as we're weighing the positivity of the test, but I can remember several patients. I checked this morning with one of my great colleagues. There are 65 patients that we have that had true symptoms of COVID-19, but were PCR negative when we ran their tests. Some of these were healthcare workers, and one particular patient I remember very vividly works in a nursing home and has known exposures, but her tests came back negative. This other great colleague that I have sent a link that I would like to refer you all to that has a bunch of great information for persons in resource-limited settings when it comes to COVID-19 and development of protocols. So COVID-19 Humanitarian is a website that was developed in conjunction with the World Health Organization, and it has lots of information and interventions for resource-limited settings. Of note, I would like to point you all to the risk assessment guides that they have, which are actually really great for persons in resource-limited settings, and particularly they do address the needs for patients in maternal child health clinics, assessing the number of midwives and assessing exactly what you need to have a good plan for going forward in education and things that are needed in your community. Thank you all for your attention, and I look forward to answering questions in a few more minutes.
Thank you so much, Dr. Wright, for your perspective on what's been happening in your hospital. I'm now going to introduce Dr. Diana Wolfe, who works with Dr. Wright at Montefiore and Albert Einstein College of Medicine. She's also in the Division of Maternal-Fetal Medicine. Thanks a lot.
Thank you, Dr. Stringer, for your kind introduction, and thank you to SMFM for this opportunity. I hope wherever our participants are in this world that you are safe and sound. So I am going to speak about the triage of pregnant patients who test positive for COVID-19. First step is to identify the severity of disease, especially regarding oxygen saturation. We have found that the majority of patients are asymptomatic, but test positive. There are patients with mild disease, those who have flu-like symptoms such as fever, cough, myalgias, anosmia, in other words, loss of smell, and dyspnea. These patients can be managed as outpatient, but it's important to remember to advise them to quarantine for 14 days and to follow up with telehealth, that is, with close monitoring by telephone. But it's also important to remember that those patients with comorbidities are at high risk for developing moderate disease, which is defined as evidence of lower respiratory tract disease, dyspnea, pneumonia, or seen on imaging, lung involvement, abnormal arterial blood gas, and refractory fever. There's then severe disease, which severe disease is where there's evidence of real hypoxia. That is respiratory rate greater than 30 breaths per minute, oxygen desaturation less than 93% on room air, or a ratio of arterial partial pressure of oxygen over fractionated inspiratory oxygen of less than 300, or greater than 50% of lung involvement seen on image. And then, of course, we have the critical disease, which involves organ failure. All of these patients, it's advised to admit them to the hospital for inpatient management. So once you have your patient under investigation or your confirmed COVID positive pregnant patient admitted, it's advised to place them on contact and droplet isolation, and also to test for other respiratory pathogens as they may involve other additional treatment. Labs, if possible, are to order are as listed here, and a chest x-ray, if available, is useful. It's important to remember to avoid volume overload and also to provide DVT prophylaxis, whether it's through medication or through compression device. We have found that the following indications are prognosis for result in poor prognosis, including elevated C-reactive protein, increased procalcitonin, low platelets, evidence of disseminated intravascular coagulopathy, those who require supplemental oxygenation, and again, remember patients with comorbidities such as chronic hypertension, diabetes, renal disease, cardiopulmonary disease, including asthma, and those who are immunosuppressed either with medication or who have intrinsic disease are all at risk for decompensation. So let's talk about that decompensated patient for a moment. This includes the patient who has worsening dyspnea or tachypnea, patients who have significant desaturation, less than 96%, those who are using their accessory respiratory muscles, and those who have an inability to complete a full sentence. These are patients who will most likely need supplemental oxygen, and it's advised to start with a nasal cannula at 2 to 4 liters and increase as needed up to 10 liters. Once your patient is on 10 liters of oxygen, it's advised to switch to high flow nasal cannula. If that doesn't work, then continuous positive airway pressure, otherwise known as CPAP, and ultimately, if necessary, intubation. Now, it really depends on what's available at your facility, of course, and we have found in our facility that providing a bedside commode or an extended nasal cannula is useful, such that when these patients ambulate to the bathroom, they can still benefit from the supplemental oxygen. We've also found it very useful to place baby monitors in the room next to the continuous monitor of the patient, such that we have reduced staff exposure to the patient, so we can visualize the oxygen saturation, the heart rate, and so on continuously without going in and out of the patient's room. So if these devices are available, we have found them to be useful. Now, your patient who requires at least 10 liters on nasal cannula, let's talk about that for a moment. These are patients who are really at risk for intubation, and you want to think about airborne precautions, because if they are going to be intubated, well, there's a risk of aerolized infectious particle exposure to your staff. So a negative pressure room is advised. And also, it has been found that placing these patients in the prone position, whether they're intubated or not, is useful. If they are intubated, you want to be careful not to disrupt the placement of the endotracheal device. Now, patients who require 10 liters of nasal cannula, it's advised to switch them to the high flow nasal cannula if available, to repeat the labs, repeat the chest x-ray imaging, involve your critical care colleagues so you can co-manage with an intensivist, and also, if possible, do a bedside sonogram of the patient's heart, lungs, and of the fetus. And again, if possible, move these patients to a negative pressure room. I just want to emphasize the concern for aerolizing infectious particle exposure to staff members. Now, when to intubate? That is the question. Making this decision is really individualized, and the patients who really are at most concern are listed here, and those who you want to consider intubation, including patients who are on greater than 15 liters per minute nasal cannula or mask, those who are on greater than 40 to 50 liters per minute by high flow nasal cannula, those who are on greater than 60% fractionated inspiratory oxygen by Ventura mask, and those who cannot protect their airway. Now, if intubation is not available and it's not possible, then it's advised to continue your nasal cannula at 15 liters per minute, face mask, otherwise known as non-rebreather, at 15 liters per minute, up to 50 liters per minute, but that may involve additional resources to get to that high level of oxygenation. Ventura face mask via fractionated inspiratory oxygen, and then of course there's the BiPAP or CPAP options. So thank you for listening, and can't wait to hear the discussion further.
Thank you so much, Dr. Wolfe. We're now going to have our last presentation by Dr. Rebecca Zash. She is an assistant professor of medicine at Harvard, and she specializes in infectious diseases and has done a lot of work in Botswana. Take it away, Dr. Zash.
Great. Sorry, I was muted. Thanks so much for inviting me. I'm an adult infectious disease doctor, but I have spent a lot of my career living and doing research in Botswana on HIV and pregnancy. And we up in Boston haven't been hit quite as hard as New York, but we've had lots and lots of COVID patients over the last few months. So I just wanted to talk pretty briefly on the treatments that we know about for COVID-19. So I'm going to start with the punchline, which is that we really still don't have an effective treatment for COVID-19. And most of the initially promising treatments from case reports and small observational studies haven't shown any efficacy in larger trials, or at least not yet. And that's not to be super depressed. There is a lot going on in the pipeline. But today I'm just going to go over pretty briefly the medications that we do have some trial data for. So I'll start with the immune modulators. And for example, these are IL-6 inhibitors. The rationale for using IL-6 inhibitors is this second phase of COVID, which is inflammatory, which is a cytokine storm, which does tissue damage, and is associated with high levels of the cytokine IL-6. There's really extremely limited clinical data on IL-6 inhibitors in pregnancy. There's some thought that just regular elevated IL-6 is not good in early pregnancy, associated with miscarriage, maybe preterm delivery. And most COVID-19 IL-6 inhibitor trials have excluded pregnant women, but not all. People got excited with this early data, which was an observational study of 21 patients with the IL-6 inhibitor tocilizumab. 20 of the patients improved, and they had decreasing inflammation, they had decreasing temperature fever curves, and they had improvements in oxygenation. But now that we have data from larger trials, it's really less clear if these are going to work. There's some data from France in a trial comparing tocilizumab with standard of care that is unpublished. They announced via a press release that there was significantly lower death or mechanical ventilation in the tocilizumab arm, but then the entire data safety and monitoring board resigned, so we don't really know, and this is yet unpublished. A different IL-6 inhibitor called sarilumab is being compared to placebo. These data are also unpublished, but recently they announced that there was a negative trend in severe disease, and so stopped this arm of the trial, although there is still an arm going in critical disease. Then on to BCG vaccine, and the rationale here for BCG is that we think that it actually trains the innate immune system to respond better to many different kinds of infections, not just tuberculosis. CDC and WHO do not recommend BCG vaccine in pregnancy, although this is really not because of any specific known harm, but just because of complete lack of data. And people got excited about this, again, from an early study where basically what they did is they look at COVID death rates in countries with universal BCG policies here and compared them to death rates in non-BCG countries, and it looked like there might be a trend. But now that we've gotten some individual level data, it really doesn't seem that BCG vaccine is going to have an impact on COVID. I think it's important the WHO announced that they're going to recommend against the use of BCG vaccine for COVID outside a clinical trial for lots of reasons, including that it may not work, but also because BCG is really in short supply around the world and wouldn't want it to be used up for this indication. Moving on to antiviral and anti-inflammatory combinations. This is hydroxychloroquine. It has some in vitro data that it has antiviral activity, and it's used for anti-inflammation in some rheumatoid diseases and like lupus. There's a lot of pregnancy safety data for hydroxychloroquine because women who are pregnant with lupus are often treated with this. And ACOG has listed hydroxychloroquine as having a low risk for teratogenicity. The excitement around hydroxychloroquine really came from this early study in France of 36 patients. And they found that patients on hydroxychloroquine, in that red line here, had faster viral clearance. and that when hydroxychloroquine was combined with azithromycin, which was this green line here, they had maybe even faster viral clearance. But once again, the subsequent studies really haven't seen this effect seen in an early trial. So there have been more than 10 now published studies showing no benefit, including 2 very large studies in New York, which were observational, and multiple randomized control trials. And I think there's also some concern now that there could be an increased risk of cardiac side effects. This is because in this study in Brazil was stopped early, and they were trialing chloroquine and not hydroxychloroquine, but they actually had increased mortality in the chloroquine arm. And then this is a table from the New York study that shows that in patients on hydroxychloroquine, especially when it was combined with azithromycin, had 2-fold higher risk of cardiac arrest and higher risks of abnormal ECG findings. And now I'll move on to the antivirals. The first is Lopinavir-ritonavir, a protease inhibitor antiviral drug that's widely used for HIV and has in vitro activity against multiple different coronaviruses. We have lots of pregnancy safety data on Lopinavir-ritonavir because of its widespread use for pregnant women with HIV. And there is some data suggesting an increased risk of preterm delivery. Most of this data comes from women who have been on Lopinavir-ritonavir for all or most of their pregnancy, so very long duration. But the, again, data for Lopinavir from trials is really not looking so good. There's some in vitro data that says that the concentrations would need to be 40 to 60 times higher than what's achieved with our standard HIV dosing to be able to inhibit SARS-CoV-2, and 2 randomized control trials, one in patients with severe disease and one in patients with mild and moderate disease, haven't shown any benefit for Lopinavir-ritonavir. And lastly, there's remdesivir, which has gotten a lot of attention here in the last few weeks. It's an antiviral drug that was previously tested against Ebola virus, but failed. And has in vitro activity, again, against a lot of different coronaviruses, including SARS-CoV-2. About a week and a half ago, 2 trials reported. The first was a randomized controlled trial from Wuhan that was published. They actually stopped early because they couldn't enroll any more patients. There weren't enough coronavirus patients around. So they ended up with about 200 patients and no difference in time to clinical improvement. And then pretty much the same day, there was a report of the US ACTT trial, which enrolled over 1,000 patients and randomized them to remdesivir. Again, this is unpublished. This is just from press release, but they reported a faster recovery with remdesivir, 11 versus 15 days, and a non-significant lower mortality with remdesivir of 8 versus 11.6%. Pregnant women were excluded from ACTT and the Wuhan trials, but actually they weren't excluded from the prior Ebola trial. There were 6 patients in that trial who were pregnant who were randomized to remdesivir with no adverse events. And we also have quite a number of women who's received remdesivir for COVID in this compassionate use program, well over 100, and the data are currently unpublished, but we understand that they're going to be coming out soon. So the authorities in the United States have decided now that they're going to release remdesivir for clinical use under an emergency use authorization, they're not going to exclude pregnant women from this. And they suggest discussing the risks and the benefits, which is very difficult without any published data on remdesivir to kind of really understand what the risks and benefits might be. But that's where we are with remdesivir. And I just wanted to end on a slightly higher note to say that there's been a really amazing amount of advocacy around including women and pregnant women in COVID treatment trials. There have been several papers published in very high-profile journals speaking to this. And although pregnant women were not included in a lot of the initial trials, now there's several large adaptive treatment trials which will not exclude pregnancy, including a 90-country WHO study and very large studies in the UK and the US. And I think it's really important that we continue this advocacy because we're going to need a very similar approach to vaccines. And there's been a great paper published this week in Vaccine on how we might think about including pregnant women. And I'll stop there, and I look forward to the questions.
Thank you so much, Dr. Zash. I will say that at our hospital in North Carolina, our pregnant women are primarily receiving remdesivir who have COVID. They're offering it for compassionate usage, and they are receiving it. So now I'm going to turn to the questions. And this question, we're going to start with Dr. Adesina and then some of the other providers. What PPE do you recommend in the labor and delivery room in low resource settings where there are shortages of PPE? And I think that this was probably relevant in New York as well when you also had shortages in the beginning. And what is kind of what's the best, and then what can just protect you? I guess that's kind of what the question is. Do you want to respond first, Dr. Adesina, and then have others chime in?
Yes, I will. Let me respond because, of course, the PPE are in acute shortage with us, and I think I always tell people globally. But in the labor ward, at least one of the things we insist on is the patients must have the face mask, must be masked. The healthcare providers also mask, and then if you are going to have sterilizing procedures, you must have the N95. We try and make sure that that is available. And also more recently, we're also making sure that you have the face shields available so that we can increase the protection. But then, like I said, testing has been an issue. And so it's sometimes like walking in the dark, really. So, but at least we try and make sure if you're going to have sterilizing procedures, make sure you have N95 available for that.
Would anyone else like to comment?
Yes.
Yeah, so I mean, I think, one of the points I was hoping to make is that, most transmission is by respiratory droplets, and a regular surgical mask or even a cloth mask that patients can make at home will be very, very helpful in decreasing the amount of spread of virus from both from patients to providers and from providers to patients and between providers. So that goes a long way. So even if you don't have N95s available or even big face shields available, just simply wearing a mask is very, very helpful. But also bear in mind that when someone is pushing in labor, that is potentially a time when larger amounts of virus are going to be expressed into the room because they're breathing heavily, and there's some studies that have shown that any situation that increases the amount of the work of breathing increases the amount of virus is spread. So that's the time, if you can, to try and wear a full PPE as best as you can.
Thank you. So we have another question, and it's, what is the significance of placing the patient in a prone position? And I know that we don't typically, at our hospital, we don't typically place our pregnant women in prone positions, right? And I think that can be challenging, and I'm sure, if you have a limited amount of oxygen, let's say you can't intubate, or you have limited high flow nasal cannula, like putting a pregnant patient in a prone position, how much benefit are you guys seeing, and are you doing this routinely?
So I'll attempt to answer that question since I recommended it. It's theoretically supposed to help oxygenation to the lungs. We do recognize that it's challenging for a pregnant patient, obviously because of their belly. In our hospital, it's been done mostly with non-pregnant patients, but it is recommended to, if the supplemental oxygenation is not working or you don't have any other modalities available, it is an option. But of course, you have to take into account patient comfort, that it may not be the most comfortable position for a woman in pregnancy. However, it has been described as safe.
Are you guys routinely putting your COVID positive pregnant women in the unit who are in a unit setting in the prone position?
We have not been routinely doing it. It's really, the prone positioning has been reserved for patients who are really not responding and are continue to be critical. So fortunately, we haven't had many instances where we needed to do that because we do have good oxygen available for them. But it is believed to increase the amount of oxygen that goes to the lower portion of the lungs by placing them in the prone position. Fortunately, it's not routine.
I was trying to group the questions into categories, although I'm not doing a great job with that, so we just have to give me a pass on that. Dr. Adesina, there are a couple questions regarding, like, how do you mitigate for fake testing in Nigeria? And I think fake testing is maybe a concern in many places in the country. So that's a question. And then, yeah, let's start.
Of course, when you have this kind of pressure and demand, you're going to have a lot of fake tests. But one thing I always tell people is we go by the recommendation of NCDC. The NCDC recommends an accredited lab. Right now, they're also trying to evaluate some test kits for antibodies. But I think it is always best. I know that some people in the community have started using some tests, but I think it's better to, I think it is better that we go by what NCDC goes. That is what I always recommend to people, because it can be traumatic if you give a test result to somebody who is negative and then you tell them they are positive, or the person is positive and then you tell them they are negative. I mean, I think that can be catastrophic, and you really don't want to do that kind of thing. So that's my take on that.
And I'd also just like to say that we haven't had that many COVID positive patients in our hospital, but we've had 2 patients who were originally tested negative, and then their test came back positive several days later, and many providers were potentially exposed because they weren't wearing the proper PPE, like eye protection. And so there is a plug to try to wear as best universal PPE when you're seeing patients on the labor ward, right? Like a mask and maybe even a face shield or goggles or something. There's a question that came through, and I guess this is for anyone. For the patients who do have preeclampsia, who are COVID positive, so maybe they have 2 diagnoses, for the patient with preeclampsia, do they likely have fever? Can they have fever too, or can they have COVID and preeclampsia and no fever? Is it always accompanied with fever? I guess that's what the question.
So the big challenge with that is that 60 of our patients, 60% with COVID were asymptomatic, and there are patients who have tested COVID positive and only had elevated blood pressures or a syndrome that looks like preeclampsia. So it can be a very, very confusing picture. So yes, you can have a patient who's COVID positive and has a picture that looks like preeclampsia that could potentially be related to the COVID as opposed to a true preeclampsia.
A question kind of related to that just came through. I guess we're looking at mortality rates, and with eclampsia, like has that increased mortality, or you treated them with magnesium and they survived, or kind of how did you treat the eclamptic patients? Did you treat them any differently with COVID?
We did not. I mean, we treated them as you would any eclamptic patient, with stabilizing their blood pressures, giving magnesium, and then expedited delivery as soon as possible afterwards. And the mortality, we haven't had any deaths from eclampsia. Thank
you, Dr. Wright. With the questions that were sent in before and now on the chat list, there is a question about, it's really about timing of delivery. And if you deliver a patient, does she get better? And then if she's very early and she terminates is there an indication for termination to improve the health of the mother? And so I think that really stems from, is delivery indicated and when, and have you seen patients getting better after delivery? And I know this, we've all grappled with this, right? When to deliver a COVID patient? And I think people are struggling with that worldwide. And I guess I'd like to know you guys' experience with that.
So I can attempt to answer this question. In our facility, so first of all, we really don't know. We don't have enough information right now to have a 100% recommendation. However, what we have done at our institution is we've agreed that if the patient is around 34 weeks and they are critically ill, that they may benefit from delivery. Just their cardiopulmonary status may ameliorate without having this big abdominal mass, the pregnancy inside. However, if the patients are very preterm, we really have to weigh the risks and benefits. Risks to delivering a 26-weeker or 26-7-weeker. I know that speaking to other colleagues in the New York area who've had very critically ill patients, where the pregnancy is 23, 24 weeks, they do not intervene for the baby. It's really for maternal status because the fetal prognosis is poor in that very peri-viable, very early preterm gestational age.
And it's probably, so therefore it may not be seen to benefit, the mom may not benefit from early delivery in that early gestational age, I guess.
Right, that's what it appears to be at this time.
Okay, thank you. I just had a question come through to Dr. Zash. Do you have comments from the Grain et al. Paper in the New England Journal on compassionate use of remdesivir for patients with severe COVID?
Yeah, I mean, what I can say is that we're just living in a time where there's overwhelming number of papers being published, and trying to tease out what's helpful for clinical use is really hard, especially because it's not all published and we're getting these reports. So I think, the best published randomized controlled trial we have right now, where there's a comparator group, which is really important in looking at this data, because without a comparator group, it's just impossible. People do poorly. So it's an impossible situation to sort of know what it means to just look at a bunch of people who got something without a comparator. So I'd really just go back to the Wuhan trial and the hopefully soon to be published ACTT trial for the data on remdesivir. Again, I think people are hopeful because we really would love to have something. But right now it looks like maybe a benefit in the number of days till improvement, and maybe a very small mortality benefit, but that's really not clear.
Thank you so much. So another question that's come up regarding, we talked about timing of delivery, is mode of delivery. And I think that people, again, across the world are struggling with this, right? Like, should we just go ahead and get the patient delivered quickly by C-section? And also what type of anesthesia should we give her? Can you all talk about mode of delivery?
So I guess, Dr. Adesina may want to comment on this as well. I mean, a lot of it's really going to depend on the resources where you are and the ability to do cesarean. So when we looked at our data, over 90% of our patients who were critical and were delivered by cesarean, and 50% of those who had severe disease and were delivered by cesarean. The rationale behind that is that if you're attempting an induction of labor, especially for somebody who's not coming in with any contractions and possibly a long closed cervix to start with, and they are critically ill, I mean, you don't want them to go through a prolonged labor if they can help it. So we've been primarily delivering by cesarean if they're critical, especially for those that we are delivering specifically for their critical illness. It's been by cesarean. In terms of anesthesia, of course, well, Ideally spinal. However, there were at least 4 patients that I can think of that were acutely decompensating. So we essentially intubated them, performed a cesarean, and then they went to the ICU while still intubated for respiratory management. And all 4 of them actually did quite well immediately after delivery. They did improve shortly afterwards. So in general, yes, we would ideally like to do a spinal because that obviously decreases the risk of aerosolizing particles for the staff. However, you know, if somebody's going to be intubated anyway, that's an opportune time to perform the cesarean under general anesthesia.
Okay.
Thank you. There have been a couple questions about maternal child transmission of COVID and so could any of you comment on that, please? I know that when you look in the literature, it seems that there isn't MTCT, but then there have been a few case reports. So I would be interested in knowing y'all's answers on that.
So amongst our New York City cohort of 240 deliveries, there were 3 or 4 babies that were born believed to have been vertical transmission from mother to child. And the way I think about it, it's probably a situation fairly analogous to HIV. The vast majority, 75% of patients with HIV don't transmit the virus to their babies, regardless, if they don't have any intervention. But it's usually those with the high viral loads have other insults to the placenta that allows the virus to get across from mother to child. And it's probably a similar mechanism or a similar kind of phenomenon happening with COVID. Like, the hypothesis is that those who have incredibly high viral loads may have more inflammatory response and damage to the placenta that might allow the virus to get across from mother to child. But we do have some, as 97% of our patients do not transmit from mother to child, but it is possible.
And in your hospitals, or in the moms who are not severe or critical, are you allowing the moms and babies to be together?
Yes, we are. Our neonatology colleagues are allowing the moms and the babies to be together.
And are you giving them special instructions that could be translated to low-income settings? What do you tell them, or is it just kind of business as usual?
So for those patients who are positive, they're advised to wear masks at home, also quarantine themselves for at least 14 days, and to social distance themselves from other family members within the household.
Yeah, so also hand washing is important. And we know there's definitely benefit, well, we believe there's definitely benefit of breastfeeding, and there's antibodies that get transferred from mother to child just by the act of breastfeeding. So in general, that's encouraged, and especially in resource limited settings where the availability of formula is not great. I know that there was a question earlier sent through email about breastfeeding. I would encourage breastfeeding because it can be protective for the babies. And babies that babies that have had COVID have done very, very well. And our data do support that as well as we follow the babies out for a few months now. But hand washing, wearing a mask, and when the mom is not breastfeeding or actively tending to the child, have the child more than 6 feet away from the mom is recommended.
There's another question which is about negative pressure rooms. And we know that many places do not have these. And so this was actually a question directed to Dr. Adesina, and other people can comment. If you don't have a negative pressure room, like when I worked in Zambia, they didn't have them in the hospital. How do you create an environment where providers and patients are kept safe? Dr. Adesina?
On the resources. Yes, I hope you can hear me.
We hear you now, yes.
Okay, thank you. So it places a strain on the resources. What you had to do, because of course we don't have negative pressure rooms, is that if the patient is in the room and the care providers go in with the full PPE, But once the patient leaves, the whole suite has to be decontaminated. It means nobody will be able to use that room or that suite for that period. That is what, because obviously we don't have the resources, at least where I practice, for that. So that is the challenge with that. The other things that I've heard people talk about is make sure that wherever you attend to the patient, as much as possible, is also well ventilated, so that hopefully you can reduce the load of virus in the air and in the environment. So, but definitely protection with full PPE is necessary, and then decontamination once, and disinfection once the patient leaves that room. So, but if people have had the experience with negative pressure, it would be nice to hear how that operates, how that goes.
In the hospital, one of the hospitals where we worked in Rwanda did not have negative pressure, but they did have a large HEPA filter that was portable. It could be transported from room to room. So, and we've done that here. I mean, all of our rooms, I mean, at one point, this particular hospital where I'm sitting now had 200 COVID patients in it at one time.
Wow.
So we clearly don't have 200 negative pressure rooms. So there are HEPA filters, that large portable HEPA filters that we used in rooms where there are going to be aerosolizing procedures performed that are available in many resource limited settings.
And the other thing that we've done here as well, which can be helpful, is really thinking about designing the space before the numbers increase of, can you keep a section for COVID, and can you possibly cohort, and trying to think of these design issues first, because that can really help with, if you just have a limited number of HEPA filters or rooms that open to the air, things like that.
Thank you.
Thank you very
This
much.
has been, thank you all for participating. This has been a really amazing webinar. There are lots of questions that we cannot get to, especially a lot of questions also about keeping providers safe in surgery, reducing mother to child transmission. There's a lot of interest in that. And so I'm going to suggest that we create a document with FAQs with as much information as we can that we can distribute to the webinar participants at the end. And it'll probably take a week or two to get that ready. And then do you guys have any last comments before we wrap up and say goodbye?
One additional comment that I didn't mention about delivery is certainly antenatal corticosteroids are recommended in viable, critically ill patients with COVID.
So, and I think that there is debate about that. About at what gestational age, like what is the upper limit of the gestational age where you would give the antenatal steroids? Are you, I know we're supposed to be wrapping up, but do you guys use a cutoff or do you extend it?
Certainly, because you don't, right. So it's almost like a PPROM patient. You don't want to increase the, their risk of becoming of severity of disease. So between 30, I wouldn't give it between 34 and 37 weeks, the late preterm period, but definitely between 24 and 34 weeks, I would give antenatal corticosteroid.
Okay. Any closing remarks, Dr. Adesina?
Oh, yes. I think one thing that, I think COVID, it's going to be with us for quite a while. I think one thing that some of us in the low resource setting really look forward to is if we'll have a point of care diagnostics. The way this reminds me so much of how HIV started, those days of the early days of HIV, everything about it, the isolation, how do you take care of the baby, what do you do for the care provider, the exposure of the care provider. I mean, it just reminds me so much. And having point of care diagnostics really simplified a lot of things. And I think that is something that I think a lot of us would really look forward to if that could be available. But while that is not available, I think people should continue to be proactive, plan, and seek knowledge so that they get ready for that first COVID-19 patient that they're going to come across and care for. Thank you.
Thank you. Dr. Zash?
I think just, one point to emphasize is that from an infection control standpoint, very good hand hygiene and covering of the nose and the mouth will get us really, really far in preventing both the patients getting it from providers and providers getting it from patients. And then I think one of the positives that has come out of this in Boston is that we've had an amazing collaboration with OB and ID and across institutions. And I hope that sort of is something that also happens as it spreads around the globe, because it's really brought us closer in some ways.
And in many hospitals, I mean, the obstetricians are not talking to the infectious disease doctors ever, right? And so it's made us meet new colleagues. Dr. Wright?
So just to encourage everyone to stay strong and remember that we are scientists. This is the message I gave to our department as well. We know how to look at data. We know how to make clinical decisions. Even in the absence of some concrete data, we know how to make good clinical decisions. And this brings us all back to the basics of medicine that we learned in medical school. And especially, I feel like I'm back in a resource limited setting here in New York City, because, a lot of things we just didn't know, didn't have the resources for that we expected. So remember your basic medicine, remember your basic hand hygiene. And the last thing is support each other. It's been incredibly challenging for all of us, seeing the amount of death and our colleagues getting sick and our friends and families getting sick. So be there for each other and support each other, because this truly is a global pandemic and a global crisis for all of us.
So thank you so much, Dr. Wright. Any fleeting more comments, Dr. Wolfe?
Yeah, no, I just want to second what Dr. Wright just said, and that is that we're in this together. This is a global pandemic, and it's really brought everybody together in our community, and I hope worldwide, that we don't have any barriers to supporting one another, that we are here for you if questions come up. We want to be supportive.
Thank you all. That concludes our webinar. I would love to somehow get feedback from the participants to see how we can, if we should do another one of these, and if this is a good format. And I hope this is not the last one that we do. And I just want to thank everyone and hope you have a good weekend. Bye.
Thank you.
Thank you.
Thank you.